Assalamu alaikum, and thank you. Let me put my timer on so that I don't overshoot the time, right? Right. So, my talk is titled Osteoporosis Fact Check, because although it is one of the commonest, perhaps the commonest diseases in the world, we are all very confused about it. And again, the reason why it is such a confusing topic is because nobody really knows who is the person who is supposed to be looking after this disease. Is it an endocrinologist domain? Is it a rheumatologist domain? Is it an orthopedic surgeon's domain? Or is it a geriatrician's domain? And the answer is, in fact, everyone, and also the primary care physicians and the specialists in internal medicine, the physical therapists, occupational therapists. It is a problem which affects all of us, and it affects us also in a very personal context, because like it or not, we are all one day going to have to face this. So let's begin. I do not have any disclosures, and briefly I am going to be talking about, first of all, the challenge we face, and the challenge of osteoporosis, which is perhaps the most unrecognized and undiagnosed disease in the world. And then I'm going to be focusing my talk intensely on matters which confuse us, what I like to call the enigmas, because these, however much we read about this, these are things which continue to confuse the resident fellows and also many of us, be whatever stage in life we are at. So, first of all, I'd like to share this patient of mine. She was a very elderly lady, and in her time she had been a very active person, a social worker, but unfortunately at this stage of life, and she's 82 years old, she's living alone. She's taken care of by some carers in her home and some home nursing facilities. She has dementia, she has limited mobility, diet as in elderly people is very insufficient. And so one day, and she has, because of dementia, she's on some medication for that. And one day, her carers notice that this is how her hand is, and they contact me. The question here is that, is this story just beginning here? Or is it the ending? Or is it the beginning of the end? Because this is something which is the sentinel event which basically begins the downward decline. 1 in 20 Pakistanis is living abroad. That is 10 million, 1 crore Pakistanis are outside. And what is happening here is that their parents are left here alone, and they are living here alone. They are alone, they are becoming frail, and their vision is falling. And this is the problem we have. I call it the parent problem, but nobody actually thinks about it when they go abroad. It's a global problem. The world is aging. And Asia, which was typically the youngest of the somebody just said in the pediatric rheumatology presentation that we have the largest pediatric population in the world. But we are also projected, the number of people over the age of 60 is expected to triple in this part of the world in the next few decades. So we too are going to be facing the aging population, but unfortunately we do not have the mindset, the resources, and the preparedness to look after this aging population. So osteoporosis, what is it? Stated simply, it means porous bones. And the bones which become porous are the precursors to a lot of problems. And it's a huge problem. It's a silent disease, but it affects nearly 250 million people in the world. It's a very large percentage of the population. It's a silent disease. Nobody knows you have it until this happens, a fragility fracture, which is defined as a fracture when if I just fall while I'm standing here, I have a fracture. That's a fragility fracture, because I shouldn't fracture my bone if I just fall from this height. But if I do, that means that my bones have no longer the strength which they had at one time. And a fragility fracture is often the first thing. As I said, it is the beginning of the end. A fragility fracture leads to very drastic consequences. Fully 1/2 of people who have a fragility fracture of the hip become immobilized, become dependent. They lose their ability to move around. And 1 in 3 people with a fragility fracture of the hip, especially if they're a woman, may not last a year. So it is the beginning of the end. And we don't know it, but it is there in Pakistan also. This is our own data from a community-based surveillance study which we did. And from the ages of 51 to the age of 80, if you can see, the blue bar, the dark blue bar here, that is the bar of people who have osteoporosis. It is steadily increasing from 10%, around 10%, to more than 30% in the very elderly. And if you see the lighter blue bar, the osteopenic people, that is also increasing. So osteoporosis is here, but we need to recognize it and we need to look after it. And I'd like to ask you, like you all, to ask yourself this question, that are we going to be the one person who's going to be facing this one day? So the diagnosis. We have a very scientific thing, the ACE criteria, which basically say that if you have a bone mineral density of less than 2.5 in the regions which are typically affected by fragility fractures, or regardless of this bone mineral density, if you have a low trauma fracture, you should be labeled as a case of osteoporosis. And also the ACE stands for our field, American Association of Clinical Endocrinologists. I like that because it's a simple criterion here. For people who are osteopenic between -1 to 2.5, they can still be labeled as osteoporotic, provided they have one of the fragility fractures, or if they have a high probability of having a fracture based upon a risk prediction score such as a FRAX. So these are the criteria. So coming to DEXA, something which mystifies us all. What is it? This is a machine, the patient lies on it for about around 4 minutes for 3-region DEXA, and some people are concerned that it's a lot of radiation. It is no radiation whatsoever. Certainly maybe 1,000th of the radiation you get from a CT scan. And what does it measure? It tells you the bone mineral density. But it is important to remember that bone mineral density is not the same as bone strength. It is an important component of bone strength. It contributes about half of the bone strength. But beyond bone mineral density, there is the structure of the bone, what we call the microarchitecture. And there are other things, the capacity of the bone to deal with fractures. It's important to remember that while we think about bone mineral density a lot, we think that DEXA is the way to find out if a person has osteoporosis. Remember that fully 3/4 of fragility fractures occur in patients who do not have DEXA-defined osteoporosis. They occur in the people whom we call osteopenic. So DEXA we should not be obsessing about DEXA. So as I said, bone strength is not just bone mineral density. It is also the trabecular microarchitecture. And that is why some later DEXA machines have an intrinsic component by which they can predict the weakness, they can detect the weakness of the trabecular bone by a trabecular bone score. So just to explain that the trabecular bone score trabecally sort of like hold up the bone, just like a corrugated cardboard. And it is far more, a corrugated cardboard is far stronger than a stack of plain cardboard. So that is the importance of the trabecular structure, and we'll come back to that at a later stage. The next question, a lot of my residents are always asking, what do these T's and Z's mean, and which one should we be using? So stated simply, a T-score, it's not working, a T-score is a measure of how much bone mineral density you have lost over the years. So it compares a person to the reference young adult male. T-score is a measure of age-related decline, whereas Z-score places a person among a company of his peers, what we call the age cohort, the age and gender cohort. So T-score should be used when we're looking at age-related decline. And obviously you'll be looking at age-related decline in older people. So it should be seen in postmenopausal women and older men, and sometimes in fragility fractures. Whereas, and it is classified according to, which I just showed, that it is classified into osteopenia and osteoporosis depending upon T-scores. But remember, we do not use them in younger people. Because it compares it to the standard young adult. And in people younger than this, the comparison would not give you any significant and useful information. In younger people, we use what is known as Z-score. And here, it just tells that if you take all people of this age and gender, where does your patient stand? So within 2 standard deviations of the normal mean of all people of this age and gender, that is what is normal. But if somebody is beyond 2 standard deviation, then we call this that the patient has a low bone mineral density for this age and gender. So this is a chronological age. And this tells us that this patient, unlike everybody else, if I am 50 years old, if I have a Z-score less than 50 years old, that means that for all the people of 50 years, I have a weaker bone even than my peers. So what is wrong with me? I have to look for a secondary cause. My age doesn't account for that. So in older adults, Z-score may actually fail you. Because if you just look at Z-score, it just says that my bone mineral density is just the same as everybody else. But it doesn't take account the fact that it's still low. It's still much less than it was when I was 30 years old. So in older people, Z-score may mislead you, because it may actually not highlight the fact that there is a loss of bone mineral density. But in a younger person, Z-score will tell you that this person who should have a very good bone density is in fact not having that same kind of bone mineral density, and this patient has some cause, possibly a secondary cause. So you get a DEXA report like this. DEXA possibly only, you should know what DEXA tells you. It tells you bone mineral density. It can tell you in the T and Z score, but it also gives you a number, which is the absolute value, which is estimated value, because DEXA simply looks at how much of a beam is absorbed, and then it puts it on a film, and it's an image analysis, which tells basically how white that bone is. And the whiter the bone is, the more dense the bone is. So it's an image analysis, a 2D image analysis which is being done. Therefore, it is affected by artifacts. If there's something else which makes the bone whiter, for instance, if there's a fracture or if there is something, it will pick it up as a higher bone mineral density. But it's not obviously high. That bone is weak, but it is an artifactual effect. So you get a report like this. This is our own report, and you see that there are the 3 bars, the green, yellow, and red. So these basically, the red bar is below bone mineral density of 2.5, then the osteopenic and the normal. And according to the patient's age, you have to interpret where the patient is. It also tells in this part of the picture the various areas of this. So you have to see, and it is important because in serial images, if you get a DEXA and then you get a DEXA 3 years later, and you see that in L2 there was a 0.9, the value was 0.9, and 3 years later it's come to 0.7. So in that particular area there is a loss of bone mineral density. So DEXA is good for tracking. There are other measures. There are other measures which basically the quantitative ultrasound, the quantitative CT, which is basically same as DEXA except it gives you 3D image. Again, it bases upon the image analysis. The bone turnover markers, however, tell you that how the bone is being resorbed. So they are the bone formation markers, the P1TP, P1NP, and the bone resorption markers, which is a CTX, which basically tell you the balance between how much bone is being laid down. But again, these are not a measure of bone strength, but they do tell you that if the bone turnover is proceeding rapidly. The next question is asked as FRAX. So what is FRAX? It's a fracture risk assessment tool, WHO validated, and it is validated for many countries. And there are other tools also, but we only, I think, preferably should look at FRAX because country-specific information is available for a lot of countries. So what's the difference between FRAX and DEXA? FRAX basically predicts, it's called fracture risk assessment. So it tells you that this person has so much risk of fracture at 10 years in the major osteoporotic sites or at the hip fracture sites. Whereas DEXA estimates bone mineral density. So they don't look at the same thing. But that doesn't mean that FRAX is inferior to DEXA. FRAX gives a different information to DEXA and it should be interpreted together. So FRAX is a calculator like this. You input your age, your gender, and certain risk factors such as if you're on steroids, if you're having any previous fractures, parental fractures and all that, and it tells you in this box down here, in this box down here, what is the risk of your osteoporotic and hip fracture. And it is different for different countries, the thresholds, but this is the US threshold that more than 20% at the major osteoporotic sites and more than 3% at hip is considered high risk. The advantage of FRAX is that it can be done in a community setting without a bone mineral density. And this is our own team which is doing the FRAX in the communities and getting information of what is the fracture risk. Obviously, it doesn't measure bone mineral density, but there are other limitations also because a person may fracture not just based upon those hard factors such as the patient has this age, this gender and this, but also how frail that person is, what is his risk of falls, what is his mentation. So all these things are not in. So FRAX perhaps in some people underestimates 10-year fracture risk. And what does the FRAX, how to interpret FRAX? So when you do a patient, very simple 1-minute calculator, you get the fracture risk. Then according to the age of the patient and according to the percentage of fracture risk, you place that person's dots wherever. If it comes in the green area, it's a green signal, except for reassurance and some calcium supplementation, nothing is done. If it comes in the red area, treatment should be given regardless of anything else. If it comes in the orange area, then what you should do is that is when you need the bone mineral density, and bone mineral density then would translate it into either a high risk or a low risk area. And accordingly, for low risk, reassurance is needed. For high risk, an oral bisphosphonate along with the reassurance in calcium, vitamin D. And for very high risk, you might consider anabolic agents followed by anti-resorptives. So we have assessed a patient. Now it comes the challenge of treating this patient's osteoporosis. So we have two players in the game. We have the osteoblast and the osteoclast. Osteoblasts are the people which lay down the bones, the cells which lay down the bone, and osteoclasts are which absorb the bone. So I like to think of the osteoblast as a bricklayer and the osteoclast as a sculptor, which forms the bone into something more useful and more appropriate for the purpose it is made. And osteoporosis medication also falls along these lines. The anabolic agents, which basically work on osteoblast and increase osteoblast activity and encourage formation of new bone. And these include teriparatide and other agents of the same class. And the anti-resorptive agents, which work by blocking the osteoclast. By blocking the osteoclast, they slow the bone turnover, and the existing bone then has the opportunity to get stronger. And in this class come the bisphosphonates, denosumab, and other characters. And our main player, I think the workhorse of osteoporosis is bisphosphonate. And here again, people are confused. Are they the same? What's the difference? When to use the oral, when to use the IV? And in fact, although there are differences in the efficacy, oral including alendronate and injectable such as zoledronic acid, they all do the same thing. They increase the bone mineral density. So you would probably not prefer an oral. Orals are the first line, but if there is an oral intolerance, because they do have significant GI side effects, an injectable may have to be your resource. They also differ in whether they are given weekly, monthly, annually. So zoledronic acid is an annual injection in osteoporosis, postmenopausal osteoporosis. It may be used more frequently in other kinds of osteoporosis. The precautions are that when you give bisphosphonates, whether it's oral bisphosphonates should be taken with a lot of water, the patient should not be supine after that, and even with injectable bisphosphonates, because they tend to cause an acute phase reaction, patient should be well hydrated and have an appropriate position, calcium and vitamin D repleted state. The other question we are asked is that, is there a drug holiday? Do you give bisphosphonates indefinitely, or do you stop at some stage? And the concern here is that bisphosphonates may cause what is called low bone turnover. They may cause a form of adynamic bone. So that is why it is recommended that for oral bisphosphonates after 5 years and for injectable after 3 years, you should stop and give a holiday. And again, a longer holiday for the injectable and a shorter holiday of 2 years for alendronate. And this will give time for the bone to recover its microarchitecture. But if the patient is very high risk, if the patient has fractured, if the patient is on high dose steroids, if the patient has very high FRAS scores, you should not give a drug holiday, because the risk of stopping is more than the risk of continuing. So the issues I have already discussed. The acute phase reaction occurs in virtually every person we give zoledronic to, because it's like flu-like symptoms, pain, myalgias, feverish feeling, and this can be improved by well hydrating the patient and giving it slowly. So it's an infusion, it needs to be given slowly and given in, obviously, always in the hospital setting. There are rare concerns which people consider, including people do ask, and our fellows are very concerned about it. What is atypical femur fracture and the bisphosphonate-related osteonecrosis of the jaw? So first of all, the atypical femur fracture. It's atypical because it doesn't occur where the femur fracture normally occurs, which occurs at the neck of the femur. So this occurs below the neck. It's a shaft femur. And it's a transverse fracture. And this occurs because the bone tube, which is the cortex, is held up by a network of the trabeculae. And the network of the trabeculae in bisphosphonate and other anti-resorptive agents is not continually renewing. There might be a minor trabecular fracture, but that minor trabecular fracture which normally heals, does not heal when the patient is on bisphosphonate. So that bone that here actually leads to this transverse fracture. And on the opposite side, if you can see, in the circle here, there is this indication that this is happening on the other side also. This is an abnormal deposition of calcium, and this is producing shear stress, and this is where the next fracture will occur. And then the question of what is very scary for most people is the osteonecrosis of jaw. And is it as scary as it sounds? Because osteonecrosis of jaw simply means exposed bone in an ulcer in the mouth which doesn't heal after 8 weeks. And for us endocrinologists, we see it all the time in our diabetic foot ulcers. Happens. So in most cases, osteonecrosis of jaw is not as fearsome, as scary as it sounds. But most people think that they're going to lose half the jaw, and they are very, very scared of it. And in fact, it is classified in stages according to the depth of the ulcer. Stage 1 and stage 2, all you need to do is give them chlorhexidine mouthwashes and maybe some antibiotics, because the infection actually is the thing which is preventing the healing. It's only in the advanced stage 3 that surgical debridement may be needed. There are risk factors. So these are the people whom you should be concerned about, but that doesn't mean you do not give them bisphosphonates and let them fracture and then die within 1 year. So the person, obviously this occurs more with anti-resorptives, the more potent anti-resorptives such as zoledronic acid and denosumab. And older people on steroids, diabetes, and other local poor dental hygiene may actually contribute. The question is that how to prevent it. So before if a person is going to be put on bisphosphonates, and you know you're going to put them on bisphosphonates, good to send them to a dentist and tell them to do any dental work beforehand. It doesn't mean that you're not going to treat them, but you want to get that out of the way if any urgent dental work is there. Otherwise, you should look at their mouth and look into the condition of dentition. And this is one of my favorite slides. It comes from the Osteoporosis Foundation. It says that the comparative risk of developing an osteonecrosis of the jaw compared to being run over by a car. So it is far less than, it's vanishingly low. It's not going to happen to your patients. I have not seen any patient with osteonecrosis of the jaw. And the benefit is that, so this is the benefit here. So much an untreated fracture versus treated fracture, that is how much morbidity and mortality you can reduce. And the next thing is denosumab, which is one of our favorites. So what is denosumab basically? You know the osteoblasts and the osteoclasts which you showed in the beginning. The osteoblasts produce a chemical called the rank ligand, and that is supposed to bind to its receptor called the rank. The denosumab, basically the blue portion, is the kebab mein haddi between the rankle and the rank. And it stops the osteoblast from activating the osteoclast, and then the osteoclast is not activated, it doesn't resorb the bone. So basically that is how denosumab acts. It's an extremely effective medicine. It reduces the vertebral fracture risk amazingly. The only problem is that once you're on denosumab, you're like the lady who's riding the tiger, you cannot stop. Because this is the figure which I wanted to show you. So above, in the white portion of the figure up there is, in the upper, is how the bone mineral density is increasing on denosumab, so dramatically. But the moment you stop denosumab, it drops all the way to baseline. At the lumbar spine, at the hip, and the hip actually comes even below normal. And the bone turnover markers, which tells you how active the bone resorptive phase is, overshoot even beyond the basics. So basically what is happening is that when you are giving denosumab, the osteoclasts are stopped in a state of pre-development. The moment you remove denosumab, they become active and they are hungry, they eat the bone even more than they would have normally eaten. So that is why denosumab stopping can lead to this. Should you stop it? There's no reason to stop. So you should select the patients very carefully, because if the patient is only going to be affording it for, let's say, 1 month, one year or 2 years, then better not to give that. Use some other agent. If you think that the availability of this medicine is dodgy, don't give it. So if you think that the patient is not going to be compliant, don't give it. We will skip the anabolics and that. So this is the ACE algorithm, which basically says that when you have high-risk patients, you give the patients oral bisphosphonates and go for a second-line agent only if there is a continued decline in bone mineral density. However, in the very high-risk patient who has a prior fracture, you may start with an anti-resorptive. Afterwards, first you should give the anabolic. So you build the bone with anabolic, then give the anti-resorptive. One I wanted to share here. So this is because our joint concern. The rheumatologists are always on steroids, or I don't know. So the steroids are very bad for the bone. This is a high-dose steroid. You can see how much bone mineral density is declining on steroids. And this is very dose related. So the higher the dose, the more bone mineral density decline is. So beyond 20 milligram of prednisolone equivalent, it increases very rapidly. But it is a very transient thing, so it recovers rapidly. So you should basically, when you're putting a patient on steroids, you should use the lowest dose of steroids, and you start bisphosphonate early. The last part of my talk is preventing. Is it inevitable? Are we all going to have osteoporosis? Are we all going to fracture? Not if we look at this part of the graph. You improve the peak bone mass in our younger individuals. And how can you do that? Ensure that you get the adequate amount of calcium and vitamin D from diet. This has been shown to reduce fracture risk. There are some concerns recently that giving calcium supplements increases coronary heart disease risk, but that occurs in very high rates, that is more than 1500 milligram per day, and there is a small decline. So perhaps in those patients you would be careful. Otherwise, calcium and vitamin D reduces fracture risk. It's a simple thing. Dietary calcium. So you're recommended 1000 to 1200 milligram of calcium every day. Most people, this is our own data, are taking less than that. Cola consumption. This tree graph shows that by how much bone mineral density declines with cola consumption. Across the board in all these studies it's declining. And the more number of colas you take, the lower your bone mineral density decreases, and especially in women and especially in hip. So cola consumption is so dangerous. Next time. But it's not all about. We have traps in our house. Our elderly people, our parents are living with failing vision, poor balance, forgetfulness, medicines which put them in a state of drowsiness. And then there are traps, like these stairs. So a normal stair should not be higher than 7 inches. And it should not be narrower than 11 inches. This is, I think, 1 foot, Dr. Tafazzal. This should not be in a rheumatology conference. Okay? So you should look into that, put anti-slip pads on, and this is also a very slippery surface. This should have anti-slip pad on it. So we have traps in the house. We should make, if we are going to leave our parents alone, make your house foolproof. And preferably don't leave them alone. But then there is special, improve the balance. So Tai Chi is a form of exercise which focuses on improving the balance. And this reduces fracture risk. This is my final message. Keep your bones strong and healthy. Thank you.